Yeah, okay, so we're going to start by looking at our end-tidal CO2 monitors.
So we have two machines.
All right,
We kept them in the critical care rooms. If not in the critical care rooms, then they should be in the nurse's station.
All right, so we got different size nasal cannulas here. We got the infant neonatal one. We have the pediatric version. Then the adult one for just CO2 monitoring. It's got the little yellow on there. And then, of course, we got that other one that allows you to hook up to oxygen. Another one that lets you hook up to the end of an endotracheal tube for your intubated patients. Okay, so these are our new end-tidal CO2 monitors, which Tess is going to show us how to hook up. Okay, so this is great for if you have to measure someone's CO2 level when you are either doing procedural sedation or even when somebody is coding. You can see when they can regain spontaneous circulation. So we have various ways to set it up. So first, Tess will show you how to hook it up to an end-tidal, to a tube, endotracheal tube. You plug that yellow piece into the side of the machine. All right. And then there's another piece that goes right onto the end of the CO2, and you could see that oxygen will the oxygen tubing will hook up to the other end of there. So this goes in the middle, and that little yellow piece is the part that goes to the CO2 monitor. All right. So Tess is going to breathe in the machine, and let's see what it does. So you can see there it has a good waveform. Now Tess is going to hold her breath. Let's see what happens. You can see that it's flat. So that's how you hook it up to an endotracheal tube, but it can also be hooked up to a nasal cannula. And so there's two kinds of nasal cannulas that we have. There's ones that allow you to just do CO2 monitoring and ones that allow you to also provide oxygen. So Tess right now has the one that allows you to give oxygen. So the thing that you'll see here is this end that she's holding in her hand. So this is the part that goes on the patient. It's got that little reservoir there. And then there's in her other hand you can see the piece that you're going to have to hook up to extension tubing. So you get our standard type of our standard extension type tubing. One end goes into oxygen. Okay. And the other end just gets hooked up into the oxygen in the wall. And then the nasal cannula goes on the patient. So go ahead and put it on. This one has an orange connector on it, and it goes into the machine. So now Tess has got the nasal cannula on, and she's going to take a couple breaths, and let's see what happens. And so you can see that we can even get a waveform through a nasal cannula. So this nasal cannula allows you to use oxygen. There's a separate nasal cannula that has more yellow pieces on it, like this one right here, that doesn't need oxygen. It just allows you to do CO2 monitoring.
For severe asthma, we use it too, right?
Okay, and we can also use it for severe asthma. All right. Okay, so Tess just showed us how to hook up the end-tidal CO2 monitor to your patient, but let's look at a few of the waveforms that you might encounter. So when Tess was breathing through that endotracheal tube, you saw on the monitor the waveform looked something like this. And this is a normal waveform that anyone's going to have, and it's going to measure the amount of CO2. And this, if you look at the numerical values, will go from 0 to about 35 to 40. So let's look at how this is. So when you're inhaling, there's no CO2, then you exhale, and CO2 comes out, then you inhale again, and there's 0, then you exhale, and the CO2 goes up. And then obviously when Tess held her breath, it was a flat line because there was no CO2 coming through the tubing to be measured by the monitor. So remember, that's what this thing is going to measure, exhaled CO2. So let's look at a couple cases. The first one that Tess had mentioned was in our asthmatic. And remember what's going on with the asthmatic. It takes them a long time to exhale. So it takes them a long time to get that air out, and then they finally get it out. Then they take an inhalation, and it takes a long time to get that air out. And so you can see this shark fin-like appearance here. Now also remember that the asthmatics tend to be hyperventilating, so they're breathing very fast. They're just going to get rid of a lot of CO2, so they're not going to have as much. So on the monitor, this might not be as high. Maybe it's 30 or maybe it's 25. But what happens when the asthmatic gets tired? Now the CO2 has some time to build up. So when they exhale, it's going to get much higher, and they're going to be breathing a lot less often. And so this is what you might see. A rise in the level of the CO2, and then that the respiratory rate is going to get stretched out some. Now you could ask, why not just look at the pulse ox? Can't we just look for the SAT to drop to see when our patients are doing worse? And you can. Eventually the SAT is going to drop. But remember, we're probably giving these guys oxygen, so we're artificially keeping that oxygen level high. So their breathing might be in jeopardy, but we're not going to see it. And also remember that it takes about several minutes before you can see on the pulse ox machine what's happening in the patient's body. Now the CO2 monitor, this is a breath-to-breath thing. So you're going to see this much earlier. This CO2 monitor is a much earlier warning sign. So it works better than the pulse ox. So next let's look at what's going to happen in procedural sedation. So let's say we're reducing a shoulder and we got the nasal cannula prongs on the patient with some oxygen, and they got some sedative to help them get through the procedure. So while they're still awake and while they're breathing properly, you'll see a waveform similar to the one above, where the patient exhales and inhales, exhales and inhales. Now, what can we look for when the patient starts getting too sedated and stops breathing? Well, again, remember, they're going to be holding in more CO2, and they're probably going to slow down their breathing some, so you're going to see that it's going to be stretched out a little bit, and the CO2 level is going to get higher. And if they were to stop breathing altogether, no CO2 would reach the monitor, so it would be a flat line like we saw when Tess held her breath. And then finally, let's look at resuscitations. So we know this is what it looks like when a person is breathing on their own. But let's say now we got a patient who comes in VFib and is not breathing at all. We've intubated them and we've started doing chest compressions. With the chest compressions, we're going to be circulating some blood, but it's not going to be perfect. And so you'll see that they will exhale CO2, but again, our circulation, we're not able to get all the CO2 out of the body because our chest compressions aren't going to be as effective as the patient's own heart. So you'll see waveforms similar to this, but it won't be as good. So with chest compressions, it might look like that. You can see that it's very similar, but it's a lot lower because we're not getting off enough CO2. So maybe this level is somewhere around 10 to 15. Now, we can use this same monitor to see if someone is doing crappy chest compressions, that they're not going deep enough. If you'll remember, one of the things stressed in the new ACLS guidelines are early, uninterrupted, deep chest compressions, because that is one of the few things that's going to save a patient to allow them to live. And so how do you know if someone's doing crappy chest compressions? Well, crappy chest compressions are not going to circulate enough blood, and so you'll probably see that the waveform is going to look something like this. It's going to be, you'll see little bumps there. It's going to go up and down a little bit, but not quite to the 10 to 15 level that we want with the chest compressions. Now, the end-tidal CO2 monitor allows us to do one more thing that's wonderful. Remember, we used to always have to stop chest compressions and check for a pulse? Well, we don't have to do that anymore. So remember that this represents the heart beating on its own, and then this one represents us doing the chest compressions. So if during the course of a resuscitation you got a waveform that looks like this, then all of a sudden goes to looking like this, something has obviously changed here, and we've gone from the chest compressions pumping blood to the heart pumping blood. If you see this happening, now you can stop and check for a pulse because you have a legitimate reason to check. This waveform got better. At this point, the heart's not pumping blood. We are, because the waveform's pretty crappy. So this allows us to look for the return of spontaneous circulation. So that's a quick review of some of the waveforms that we might see while doing end-tidal CO2 monitoring. If you have any questions, put them in the comments below or ask me. Okay, adios.